Um, Myself and Nishvinder are going to do an overview on arterial and venous stroke in children with cardiac disease. So let's get started. We have no relevant disclosures for the presentation, but we will be talking about antithrombotic therapies. And just to clarify that all of these therapies in children with congenital heart disease and stroke are off-label use. So here are the learning objectives. We're going to start by discussing several factors that increase risk of developing thrombosis in congenital and acquired heart disease patients, including coagulation system changes and corrective procedures. Then we're going to review current cardioembolic stroke prevention treatment recommendations in children and identify the most feared complications of initiating those treatments after cardioembolic arterial ischemic stroke. So the incidence of arterial ischemic stroke in the general pediatric population is estimated to be between 2 to 8 per 100,000. But we know that children with complex congenital heart disease, especially those with single ventricle physiology, have an increased rate as high as 132 in 100,000 or 1 in 757. And so this translates into almost a 17-fold increased risk compared to that of our general pediatric stroke population. And for the most part, cardioembolic stroke accounts for about 1/3 of all ischemic stroke in children. So paradoxically, despite improved both surgical and medical management of children with congenital heart disease, we see that the prevalence of arterial ischemic stroke in children has not really changed over several decades. And so this is probably in part due to improved medical management and surgical outcomes, which have led to decreased mortality, but have subsequently led to greater lifetime exposure of thromboembolic complications across the lifespan. And so the reason that we recommend treating children with congenital heart disease with antithrombotic therapy is because we know that they have a high risk of stroke recurrence. In fact, a study published by Lance Rodin out of Sick Kids Hospital has shown that the 10-year recurrence rate is 27% in pediatric patients, and the majority of these patients are actually receiving some form of antithrombotic therapy. We know that the hazard ratio of stroke recurrence in children is highest within the first year of their stroke and then precipitously drops away. So this is why we're very much targeting this year from their sentinel stroke. We also know that there are increased risk of stroke with prothrombotic states at the time of their initial stroke or systemic documented infection. It's important to know that cardioembolic stroke can arise by different pathological mechanisms, and so it shouldn't be treated as one single entity. So for example, you can have formation of a mural thrombus in a dyskinetic ventricle that's not pumping well. You can have a vegetation on an abnormal heart valve. You can have arrhythmia, atrial or ventricular, pooling of blood causing non-laminar flow and secondary thrombus and embolus. Or most commonly, we think in our complex congenital heart disease patients, there's a paradoxical embolus of a venous thrombus through a right to left shunt due to a structural heart defect. And so perhaps the best way of thinking about thrombosis in children with congenital heart disease is to look at Virchow's triad. And Virchow's triad talks about alterations in blood flow, alterations in blood composition, and endothelial injury. So an example of alteration in blood flow is the changing hemodynamics that children experience as they go through staged palliative repairs, and these lead to changes in their blood rheology. We know that there is such a thing as developmental hemostasis, and so depending on your age, you can have different levels of pro and anticoagulant factors. In addition, new cardiac procedures expose children to not only cardiopulmonary bypass by ventricular assist devices and ECMO, and can lead to hemodilutional changes and acute coagulation derangements. And several studies have also shown that genetic and acquired thrombophilias occur at a greater frequency in children with cardiac disease and stroke compared to age-matched and healthy controls. In terms of endothelial injury, we know that children that undergo staged repairs often are in the ICU and have central venous lines, and these lines can increase the incidence of a systemic venous thrombus that can travel through the right to left shunt. And then, as I mentioned previously, there's sometimes need for mechanical circulatory support devices such as ventricular assist devices or ECMO, and they can expose blood to artificial thrombogenic material. And again, on top of that, these children are at risk for recurrent infections, different physiological and genetic responses to the medications they receive, and the underlying cardiac diagnosis and related complications. So Trish Domi et al. Had looked at 5,526 children from 1992 to 2001 at the Hospital for Sick Children that had undergone some form of heart surgery due to congenital heart disease. And what she found was that the incidence of arterial ischemic stroke and cerebral synovenous thrombosis was 5.4 cases per 100,000 in children undergoing cardiac surgery compared to controls. And what were some of the highest risk factors associated with stroke? Older age was one of them, longer duration of cardiopulmonary bypass, which makes sense when you think about the artificial thrombogenic material that you're exposed to, and reoperation, which probably is a surrogate marker of the severity of your congenital heart disease. Now, it's important to distinguish between cardioembolic stroke and white matter injury. As we are imaging more and more children with congenital heart disease preoperatively, we tend to sometimes find white matter injury, which is different from cardioembolic stroke, but also probably as a result of the hypoxic chronic hypoxemia that these children are exposed to. And we believe, as Stephen Miller has shown, that the brain of a child, even if they're born at term, acts very prematurely and is more susceptible due to selective vulnerability to these white matter injury. However, cardioembolic stroke usually leads to a distal embolus, which causes a wedge-shaped form of infarction. So children with congenital heart disease also undergo cardiac catheterization, and cardiac catheterizations can be both therapeutic and diagnostic. And so one such cardiac cath called a balloon atrial septostomy is used to often rescue the physiology of transposition of the great arteries. A study by Blaylock et al. Found that a balloon atrial septostomy was significantly associated with preoperative arterial ischemic stroke in infants with transposition of the great arteries. But there are other studies that have not found the same association. And so in different hospitals across the country and across the world, there is no specific guidelines of whether we anticoagulate pre-BAS, whether that really is necessary and prevents any further arterial ischemic stroke. And the prevalence of arterial ischemic stroke in children that undergo cardiac catheterization is estimated to be 0.28 to about 1.3%. I mentioned mechanical circulatory support devices, and those largely consist of ECMO and ventricular assist devices. And so just to point out to this chart, well, you can see that ECMO is often used to support children with heart failure. Usually the duration of ECMO can be less than 14 days of support. And so the prevalence of arterial ischemic stroke looks relatively low to the prevalence on a ventricular assist device, but that is because in ECMO, you're usually supported for a shorter duration versus on a ventricular assist device, which bridges children for a heart transplant, you may be supported for 30 days or more. The incidence of arterial ischemic stroke on ECMO is about 1 to 2 events per 1,000 days of support, compared to a lower incidence of 0.5 events per 1,000 days of support. But again, the duration of support here is longer. And so just a slide on ventricular assist devices. So the first Berlin heart was approved by the Food and Drug Administration in 2011 to support children who need a long-term transplant. And we know that stroke is the most feared complication associated with pediatric ventricular assist devices. And not only ischemic stroke, but also hemorrhagic stroke, because these children tend to be on a multitude of anticoagulant and antiplatelet therapies. And so this risk of thromboembolic complications are usually as a result of this artificial surface and thrombogenic material. And one of the known risk factors for developing an arterial ischemic stroke with a ventricular assist device is weight. So children that are less than 10 kilos had the highest risk of stroke, arterial and hemorrhagic, when compared to those that were over 10 kilograms in the first trial that had approved the Berlin heart for support in children. And so over the years, we used to use heparin, with aspirin, Plavix, dipyridamole to prevent ischemic stroke in children on VADS here at Sick Kids Hospital. But now there's the Advanced Cardiac Therapies Improving Outcome Network, in which a lot of the North American sites are part of. And now we've switched over from heparin to using something called bivalirudin, which is a direct thrombin inhibitor. And what the preliminary results from the ACTION network has shown is that the stroke rates are now down from about 30% to 12% in Berlin patients at the ACTION sites. And so I don't have enough time to talk about why this is, but I think is just an interesting finding that we wanted to stress. And so we also know that there's different stage palliative repairs that children with congenital heart disease undergo. And so it's important to know there's the Norwood, the bidirectional Glenn, and the Fontan. And at different stages of this cardiac repair, there's different risks. So for example, the most common risk in a child, the most common risk of stroke usually occurs in a child pre-Norwood. And a lot of children during the Norwood procedure have a BAS shunt, so a Blalock-Tussing shunt. And this is a shunt that basically bridges your systemic circulation to your pulmonary circulation and allows you to have good oxygenation in the lungs. And if this shunt gets obstructed, then you're no longer able to shift blood into the lungs and get oxygenated blood back to the left side of your heart. And so as a result, it's important that children with this shunt have anticoagulation or antithrombotic therapy, but at the same time, because of the undergoing shunting in the heart, they're at highest risk of arterial ischemic stroke during this perioperative period. Following the Norwood, there's the bidirectional Glenn procedure, which basically attaches your superior vena cava to your pulmonary arteries. And so all of the upper body, including your upper limbs and brain, the venous return goes down into the pulmonary arteries. And at this stage of the repair, we see less arterial ischemic stroke, but more sinovenous thrombosis, because as you can imagine, the venous return becomes decreased. And as well, there's a high risk of pulmonary embolization in this because all of the upper body directs blood into the lungs. And then finally, with the Fontan, you attach the inferior vena cava to the pulmonary arteries. And so now basically the superior vena cava and the inferior vena cava directly supply blood into the pulmonary circulation. And at this stage, we see not a homogeneous risk of stroke, but initially there is a risk of stroke, especially if there's a fenestration. But some studies have shown that if you don't have a fenestration, you're also just as likely to have a higher risk, between 3 to as high as 19%. But then even years after, 5 to 10 years after the Fontan has been completed and the fenestration has been closed, we occasionally see higher risk of stroke in the adult population with a Fontan. And this may be related to adult risk factors that develop over time, including protein losing enteropathy and atrial fibrillation, because the surgery involves the right side of the heart. So as I mentioned, stroke risk is elevated in adult congenital heart disease survivors many years after palliative cardiac repair. The estimated event rate, while it sounds low, 0.005 per patient year, compared to the general adult population, is 10 to 100 times higher than expected in the control population. And so we see that the prevalent cerebral and pulmonary thrombosis in adult patients with synovial congenital heart disease is significant. I wanted to mention that there's differences in the coagulation system of children with congenital heart disease that are causing a multitude of added synergistic risk factors for why there's higher risk of stroke. So in a typical normal heart, if you become anemic, your kidneys are going to sense that, and they're going to see that there's low oxygen carrying capacity and ask the kidneys to secrete erythropoietin, which is going to then increase normal red blood cell production and concentration. If you have a single ventricle, right to left shunt, and cyanotic congenital heart disease, you have chronic anemia and chronic arterial hypoxemia until you're corrected, probably post-Fontan. And so your kidneys sense this and release erythropoietin, which leads to increased red blood cell production and increased blood viscosity. And that is what we call decompensated erythrocytosis, because the shunting continues on and your kidneys continue to sense this arterial hypoxemia and continue to produce erythropoietin, and it becomes this vicious loop. So while your body's trying to create more red blood cells, the blood becomes viscous, and you're paradoxically reducing oxygen delivery. And as mentioned previously, genetic and acquired thrombophilias have been reported to occur at a greater frequency in children with cardiac disease and stroke compared to age-matched and healthy controls. And as I mentioned as well, prothrombotic states have been shown to be predictive of stroke occurrence in children with congenital heart disease. So the American Heart Association guidelines now recommend that it's reasonable to evaluate for most common prothrombotic states, even when another stroke risk factor has been identified. So just as an aside, in adult stroke, while we usually find one single risk factor that may have caused a stroke, in pediatric stroke, it's not usually one single risk factor. It's usually a multitude of risk factors that kind of create that perfect storm. And so we use antithrombotic therapy to prevent stroke recurrence. And there are 5 international consensus-based guidelines that exist and address the use of both antiplatelet, anticoagulant, and fibrinolytic therapies in children with ischemic stroke. And these are all off-label. We have the American Heart Association, the American College of Chest Physicians, the American Heart Association specific guideline on prevention and treatment of thrombosis in pediatric congenital heart disease by Teresa Gaglia. There's also the guidelines from the United Kingdom. Sorry, this is actually from Australia and the United Kingdom. And for the most part, this is an older diagram now, we see that antithrombotic therapy does vary geographically, with the United States using anticoagulation therapy less often than Canada and Europe, for example. And so we know that pediatric treatment guidelines are largely extrapolated from adult guidelines, in whom there's been numerous large randomized controlled trials that have been performed. But it's difficult to extrapolate those trials. As we mentioned before, children are quite different. They have different risk factors and they have different developmental hemostasis. And stroke mechanism and age-related differences limit this, again, extrapolation of adult safety data and efficacy data. So all of this is consensus-based that we talk about. And this leads to a lot of varying institutional practices, both within institutions and amongst institutions. And so why is this? Well, we always fear hemorrhagic transformation as one of the most important, this is the most important and well-studied phenomenon in adult stroke, and it really dictates management approaches. And so what we think happens is that you have a clot that forms that causes occlusion. And after a while, there's distal migration of the clot, whether that's because we go in and remove the clot with some type of mechanical thrombectomy or fibrinolytic therapy, or because the clot self-resolves. And this leads to disruption of the blood-brain barrier and what we call reperfusion injury. And so sometimes the vessels, if they've been injured enough and cannot sustain the blood pressure that then resumes. And so this leads to hemorrhagic transformation. I should also mention that hemorrhagic transformation is a very natural process and can occur in every infarct, but just to a different degree. And there's different ways of classifying hemorrhagic transformation in terms of hemorrhagic infarction and parenchymal hematoma. And just because you're on antithrombotic therapy, an antiplatelet or an anticoagulant, does not mean that you're going to have hemorrhagic transformation. But if you are at risk for hemorrhagic transformation because of a large infarct, for example, then the type of therapy you're on may amplify this hemorrhagic risk. And so I mentioned that there's a classification system for hemorrhagic transformation subtype. And we divide this into petechial hemorrhage and parenchymal hematoma. And again, this is from a large adult study in the European Cooperative Acute Stroke Study published back in 2001 that looked at these hemorrhagic transformation subtypes in adults. And we've largely extrapolated this to children. So this is petechial hemorrhage type 1 and 2 and parenchymal hematoma type 1 and 2. And so why is this important? Well, the European Cooperative Acute Stroke Study found that if you were to have hemorrhagic infarction type 1 or 2, or even parenchymal hematoma type 1 within 36 hours of your acute stroke onset, compared to those adults that did not have hemorrhagic infarction, then your risk of mortality or morbidity were the same and your 30-day MRS score was the same. But if you were to have parenchymal hematoma type 2, well, this was predictive not only of early morbidity, mortality, but an increased MRS score at 30 days. And so we largely have extrapolated this in defining how we classify hemorrhagic stroke in children, but we do see less hemorrhagic stroke compared to adults. And this may be because we use less antifibrinolytic therapies in causing this. And so I wanted to share one last slide before I transition to synovenous thrombosis, before Shvinder does. And I wanted to show you a couple of studies that looked at hemorrhagic transformation and safety of antithrombotic therapies. So this was a study by Lauren Beslow at the Children's Hospital of Philadelphia, Tal Schachter here at Sick Kids, and myself here at Sick Kids. And both Lauren Beslow and Tel Schachter looked at rates of hemorrhagic transformation within 30 days in all stroke comers. So not just congenital heart disease, but any type of stroke in children. And so you can see that the rate ranged between 30 to as high as 30 to as low as 11. I was here somewhere in the middle, 24%. However, the rate of symptomatic hemorrhagic transformation, so those parenchymal hematomas, which are much more likely to be symptomatic, ranged anywhere between 3 to 6%. And what I wanted to point out for the slide really was this ECAS, European Cooperative Acute Stroke Study grade of antithrombotic therapy associated hemorrhagic transformation. So while a large proportion of children had hemorrhagic infarction type 1 and 2 in both studies, and in this study myself, I just looked at the cardioembolic population, very few children had parenchymal hematoma type 1 and parenchymal hematoma type 2. And so there was no difference whether you were on an antiplatelet or an anticoagulant in terms of causing or potentiating hemorrhagic infarction or parenchymal hematoma. So I'm going to transition now and let Ishvinder talk about pediatric CSVT in the context of congenital heart disease.
Thank you. So in terms of pediatric CSVT, it is less common than arterial ischemic stroke in children, but similar to arterial ischemic stroke, there is a bit of a male predominance. So overall, CSVT affects 0.4 to 0.7 per 100,000 children per year. About 60 to 70% of those will be male, and neonates account for about 30 to 50% of cases. These figures are likely underestimates of the true incidence, given that particularly neonates often present with non-focal neurologic signs and symptoms, and the diagnosis may not be suspected in many cases. There's also limitations of imaging techniques, as well as the variable anatomy of sinovenous channels and rapid recanalizations, which may also contribute to underdiagnosis. The causes of CSVT in neonates and children are often multifactorial, and in about 95% of cases, a predisposing comorbid condition is identified. These can include common childhood illnesses such as infection, dehydration, and anemia, as well as chronic medical conditions such as congenital heart disease, nephrotic syndrome, and lupus. In neonatal CSVT, maternal factors may be contributory, such as chorioamnionitis, gestational diabetes, and pregnancy-induced hypertension. So as Dr. Paulsine reviewed, Virchow's triad also applies in cases of CSVT, and it highlights 3 factors that are critically important in the development of venous thrombosis. This includes venous stasis, activation of blood coagulation, and endothelial injury. We'll focus on the hypercoagulability piece, which is commonly noted in the congenital heart disease population due to factors such as dehydration and restricted fluid status, as well as anemia or iron deficiency, which we know is frequently observed in children with CSVT, although the mechanism behind this is not fully understood. There's also hyperviscosity, as Dr. Paulsine mentioned, and due to chronic liver dysfunction, there can be changes in the circulating clotting factors and proteins, leading to possibly an acquired prothrombotic state. And we know that prothrombotic states have been identified in upwards of 64% of children with CSVT and 20% of neonates. And these can be either inherited or acquired states. We also know that chronic hypoxemia can activate the inflammatory cascade, which can make the body more prothrombotic. Also, children who are on ECMO, for example, can have consumption of antithrombin that can make them more prone to clotting. And clinical symptoms of CSVT in children can frequently be nonspecific, as mentioned, and they can be subtle in neonates and children, which can lead to challenges in diagnoses and delays to treatment. Often clinical manifestations can overlap with predisposing conditions such as infection and dehydration. The clinical signs and symptoms can include seizures, which are most common in neonates, as well as altered levels of consciousness, focal neurologic deficits, including cranial nerve palsies, hemisensory loss, and hemiparesis, as well as diffuse neurologic symptoms such as headache, nausea, and vomiting. And we know focal and diffuse neurologic signs are more common in infants and older children versus neonates. In terms of neuroimaging techniques, a high index of suspicion of the diagnosis of CSVT in the acute phase is key to the neuroradiologic diagnosis, as the venous sinuses may recanalize before detection. So both CT venography as well as MRI with venography can be used for the investigation of CSVT, but each has its limitations. Given that between 1 to 2/3 of children with CSVT may have parenchymal brain lesions, such as venous infarction or hemorrhage, MRI, MRV are important in both the detection of the infarct as well as the clot within the vessels. However, given that MRV is a flow-dependent technique, it can be prone to flow artifacts, and in equivocal cases, an endoluminal technique such as high-resolution CT venography may be required to confirm the diagnosis. So we'll just quickly review venous anatomy. So venous drainage in the brain is achieved by two systems, both the superficial and the deep venous systems. The superficial system includes the cortical veins, or the superficial cortical veins, the superior sagittal sinus, the torcula, the right transverse sinus, which is dominant in most individuals, as well as the sigmoid sinus and the internal jugular vein. And the deep system consists of the vein of Galen, the straight sinus, internal cerebral veins, and the inferior sagittal sinus. The major outflow tracts, including the internal jugular veins and the extrajugular collateral venous pathways, are the main major outflow tracts. In neonates, given their supine position, the internal jugular vein is the major venous outflow tract. And so these next two slides just review the venous territories, which do differ from the arterial territories. So we know the superficial venous system supplies most of the cortex of the brain, as well as parts of the superficial and some of the deep white matter areas, and parts of the posterior fossa. And the deep venous system supplies parts of the basal forebrain and temporal cortex, as well as the basal ganglia and thalami, the deep and periventricular white matter, parts of the posterior fossa, the medullary veins of the deep white matter, as well as deep veins of the basal ganglia and thalami. In terms of pathophysiology, we know that thromboses within the venous system create outflow obstruction and ultimately venous congestion, which can lead to an increase in hydrostatic pressure within the capillaries. This drives fluid into the interstitium, producing edema. And a persistent increase in hydrostatic pressure may result in red blood cell diapedesis, red blood cell diapedesis. And if venous and capillary pressure exceeds arterial pressure, then there is a reduction in arterial inflow, leading to ischemia or venous infarction. And this diagram outlines the different types of venous injuries. So given the pathophysiology we just discussed, there is a spectrum of brain injury in children with CSVT. This can range from venous congestion, which may not be appreciable on neuroimaging, to parenchymal injury, which can be cortical or subcortical and involve deep gray-white matter. The majority of parenchymal infarcts in CSVT are hemorrhagic. In preterm and term neonates, there is also an association with IVH in CSVT. And we know deep venous thrombosis can result in hemorrhage into the ventricles as a result of blockage and hypertension in the deep venous drainage system. So similar to arterial ischemic stroke in children, there are no randomized control trials to support the use of anticoagulation. So we do use evidence-based consensus guidelines, and at our center, we follow the guidelines as suggested by the American College of Chest Physicians. And these guidelines state for neonates with cerebral sinovenous thrombosis without significant intracranial hemorrhage, anticoagulation is suggested with unfractionated heparin or low molecular weight heparin. And this is usually continued for a duration of at least 6 weeks, up to a maximum of 3 months, depending on what repeat imaging at the 6-week mark shows. And one mechanism by which anticoagulation likely exerts its benefits is through reducing the risk of thrombus propagation, and this enhances recanalization. And a study has shown that thrombus propagation occurred in upwards of 37% of untreated patients, whereas anticoagulation reduced this frequency to 7%. And for neonates that have CSVT but with significant hemorrhage, there are two kind of pathways. So one can be either to initiate anticoagulation, or the second would be to continue with supportive care with radiologic monitoring of the thromboses at 5 to 7 days. And at that point, it would be decided if anticoagulation is indicated if there's been thrombus extension at that point. And in terms of outcomes, CSVT-specific mortality is less than 10%, but neurologic deficits are present at the time of discharge or follow-up in up to 70% of survivors. We know that coma is a predictor of death in children, and many children with CSVT will suffer neurologic symptoms kind of ongoing, such as headache, visual impairment, symptoms of increased ICP, as well as seizure disorders. There was a study by Slim et al. Conducted here at Sick Kids that followed 50 children between 0 days to 18 years of age who had radiologically confirmed CSVT. And they underwent neuropsychological testing after treatment for their CSVT. And it was found that only 20% of children in the study had a normal cognitive profile, whereas 80% of children performed less than expected compared with the normative population in at least one cognitive domain. And the most prevalent impairments included processing speed of the intellectual ability, metacognition, and the global executive composite. And this included children who had CSVT without venous infarction. So it's becoming increasingly more obvious that CSVT, even without venous infarction, is not benign.
So I think we're running out of time, but thank you so much for inviting both myself and Ish. And if you have any questions, I'm happy to take them, or you can give us an email and we'll be happy to answer them.
Thank you.
Any questions from anyone? So maybe one quick question. Okay, it looks like we don't have any questions. So thank you, Dr. Paulsine and Ishvinder, for speaking to us today on cardioembolic and hemorrhagic stroke and sinus venous thrombosis, and including things like risk factors and coagulation factors and specific instances in which we see it in our children with CHD and our VADS, and also for including the evidence-based guidelines for their management. Thank you so much.
Thank you.
So our next speaker is Dr. McKinnon, and she will be speaking to us from our PICU, and she'll be talking to us on strategies for neuroprotection.
Okay. Perfect. Can everyone hear me?
Yes, we can hear you.
Perfect. Okay.